When we first initiated the project to develop the CD22 CAR, we at that point weren't aware of the loss of CD19 as a potential mechanism of leukemic resistance to the CD19 targeted therapy. But we knew that CD22 was a good target. We had developed an antibody toxin conjugate within the Center for Cancer Research that had activity in ALL and hairy cell leukemia. And so with the initial responses in ALL, we decided that CD22 CAR might eventually be useful. It turned out to be more important than we thought based on the now this observation of CD19 antigen loss. The trial was written as a standard phase 1 dose escalation trial in the sense that we started at a dose of CAR T cells that was lower than what we knew to be active in the CD19 CAR experience, really to ensure that since this was a first-in-human clinical trial, that we would be able to capture unexpected toxicity. You can only do so much to predict what toxicity you might encounter. So the trial was open. There was what's referred to as a staggered enrollment. So we had to treat a single patient. We had to see that single patient through a month to ensure that we didn't see unexpected toxicities. We treated another patient. We waited a month. And that's why the initial part of that dose escalation went quite slowly, one patient at a time. Once you feel more comfortable that the toxicity profile is sort of comparable to what was seen with the CD19 CAR, we then were allowed to enroll patients simultaneously on the trial. And at this point in the expansion cohort, we tend to treat 2 to 4 patients per month. As the trial was initiated, it became increasingly apparent that the CD19 antigen loss was going to be something that would be a potential issue with CD19 CAR treatment as a single therapy. As we began enrolling patients, many of them obviously patients, the majority of them actually patients who had received CD19 CAR and had lost CD19 expression, that became an important component of the trial, although it wasn't written that way in the beginning because we weren't aware of what that incidence of 19 loss was going to be. I think at this point, given the experience with CD19 CAR, I think one of the most important outcomes of the trial thus far is that we have a second chimeric antigen receptor besides CD19 targeted chimeric antigen receptors that has very potent activity in ALL, including ALL that loses expression of the 19 protein. And it creates really a large number of opportunities to, I think, optimize this treatment in a way that we can increase the likelihood of sustained remissions. I mean, the goal of, at least my goal of this cell-based therapy is to try to understand whether we can turn this into a definitive treatment, a curative treatment. I think the remission induction rate of 80 to 90%, those patients who don't go into remission, that's not because the CD19 CAR is inactive. They probably have a T cell that is inactive, et cetera. I think the biggest implication of this is going to be the ability to potentially chip away, if you will, at the relapses due to leukemic resistance.